Welcome to Advancing Health. Programs to transform and improve health outcomes can work well as standalones, but as we hear in this podcast, they make an even bigger difference by connecting clinical care with community-based strategies to create a coordinated ecosystem.
In healthcare, there is no shortage of innovative programs, but scaling them into a coordinated, system-wide approach is a different challenge entirely. I'm Julia Resnick, Senior Director of Health Outcomes and Care Transformation at the American Hospital Association, and this is the Advancing Health podcast. Today, I'm talking with Ryane Jackson, Vice President, Community Health Network from Memorial Hermann Health System in Houston, about what it takes to move from strong individual programs to a truly coordinated, system-wide approach, one that centers community in the strategy, integrates social drivers of health, and brings patients and partners into the work as co-designers. We'll explore how they're structuring teams and partnerships, measuring progress, and rethinking what care can look like when it's built with and for the communities they serve. Ryane, thanks so much for being here with me today.
Great. Happy to be here.
So I know that Memorial Hermann places a lot of emphasis on being community-owned, including the community in every step of the strategy. Why is that so essential to your system's approach, and how does it really influence the way you think about care and delivery and community engagement?
Yeah, that's a great question. And so just a little bit of background. I've been with Memorial Hermann now for soon to be 2 years. And, what I think is really unique about being in this healthcare system is that we do tout ourselves as community owned. And I think that is critical, I'd say, to our approach. Community owned means that we're not just providing programmings or programs or working to address their needs from the seat we sit in from a healthcare perspective, but we're letting the voice of our community, the voice of our experts in the community actually guide and shape our strategy so that whatever it is that we are providing to them, whether it's financial investments, whether it's very strategic programming designed to address, healthcare access disparities or economic disparities, we know that it is being built from the community's voice. And hopefully I answered your question. I know there was a second piece to that.
You did, and I want to get into that, like how you get community voice and that sense of ownership.
Yeah.
What are the mechanisms for engaging communities and hearing those voices and then translating them into programming?
Awesome. And so this won't be a surprise. You probably would get this answer from a lot of other healthcare systems in our country, but we do start from the place of our community health needs assessment. So we do conduct our assessment once every 3 years, and then we do annual refreshment of that assessment just to make sure that we're staying on top of the shifting landscape of our environment, especially in today's times. So the community health needs assessment, for those who may not be familiar, but I imagine if they're listening to this podcast, they're very familiar just by default. But the community health needs assessment really, in order to produce one that is worth its weight in anything, you have to talk to the community. And so we really lean into the community survey aspect of the development of that CHNA. We distribute this survey electronically, but we also provide it in person. We've been able to really leverage our thoughtful community partnerships with local nonprofit organizations, and they've allowed us to physically come in with our community health workers, with some of our own employees who may be nurses or are sitting in other roles across the system. We're asking people things, not only how old are you and what zip code do you live in, but we're wanting to understand your household income. Have you, in the last few months not been able to afford your food? What are you worried about? We're asking about mental health. Or even have asked about, have you given birth recently and were there complications? So I say all that to say the survey is very detailed and really gives us a strong picture. Then from the community voice perspective, when I talked about that earlier, in addition to the survey, we bring in those public health and leaders of these organizations to weigh in as well. They are what we consider from a healthcare system perspective, front line. Healthcare is the front line, right? They think of us, we're the front line, but these nonprofit organizations who are working directly with our community, especially those who are most vulnerable, they are the front line. So listening to the experts leading those organizations also complements that individualized, authentic voice we're getting through the survey and helps shape, where we're going to go for the next 3 years and beyond.
That's great. And so I imagine as you're coming up with your priorities from your CHNA, a lot of those health needs are parallel to the health needs that are seen in the clinical side. So, how do you think about connecting clinical strategies around those with community strategies to really maximize the impact that your work can have?
Great question. So, going back to the voice of the community, and then I'll show you how it links back to our clinical approach to the work. In that community survey and those interviews, we're learning also, what are some of the healthcare conditions that you have been diagnosed with that you are dealing with currently. And then we match that up with secondary data that helps, us determine. It looks like a lot of our community are dealing with obesity, which is a major, major issue in the country, but definitely here in Houston as well. We're one of the cities that definitely is not known for walkability compared to some of the other cities. I mean, you cannot get anywhere, barely anywhere, without a car. So if you're dealing with obesity, and we're also learning that people are dealing with diabetes and heart conditions, we then crosswalk that to see, well, how is that translating in our hospital walls? Some people don't like when we talk about this, especially in the space of community health and community benefit, where we often like to lean into, we want to help the most vulnerable, which we do, but there is a clinical and a operations aspect to it. So we crosswalk what the community has said from a healthcare perspective. We're diabetic, obesity, mental health issues, and we try to see, are we seeing the same type of conditions in our hospital walls, starting with our ER? Because I think most people can agree one of the most utilized aspects of a healthcare system is their emergency department or their emergency room. We look to see, are we seeing a lot of people coming in for these similar or related conditions? How does that translate to our readmission rates? Are they coming in for things that we think are preventable or could be managed, outside of an ER setting? Or are they coming in for very serious things that, by nature of the condition, there's not very much you can do about it? Like, I think about like cancer, and a few other things. When we're able to validate, or if we're able to validate that what we're seeing in our hospital data also corresponds with what the community is saying they're dealing with, and then all the surrounding, what we call non-medical factors. When you match it up with all the non-medical drivers, it helps us tell the full story and helps us determine, where we actually want to focus our resources. And those resources come in a variety of ways: financial resources, programmatic resources, among other things.
So, what are those priorities that you're focusing on?
So from us being able to crosswalk, what we're seeing within our hospital walls, and specifically looking at our ER data, our readmissions, and coupling it with our findings from our community health needs assessment, the voice of the community, we actually have determined that, we have the greatest opportunity to improve outcomes related to 5 key disease states: hypertension, obesity, diabetes, cardiovascular disease, and then maternal and infant health related conditions.
So you have these priorities, they impact your community health programming. How do you connect them with the clinical programming? Because, like, you could be doing the best work in the world on diabetes in the community, but if they're not getting clinical care, they'll deteriorate, and vice versa. They could be getting great diabetes care, but if they don't have access to healthy food, there's nowhere to walk, like they don't have the environment to make them healthy. It's only half of the puzzle. How do you really like connect those two sides together? Because I think a lot of health systems struggle with that.
That's a great question. So, it's always a work in progress, but I think that we're doing and we're making some really good strides, I'd say, in creating what I like to call this ecosystem of care. So, Memorial Hermann, I'd say we're somewhat unique in our approach to trying to do exactly that. How do you address and prevent some of the chronic conditions that we're seeing in our community, while also addressing some of those non-medical drivers that may have actually led to those conditions coming about? And so I'd say our approach is 2 to 3 layers of it. One, we really lean into screening for non-medical drivers of health. We have more than 40 to almost 50 community health workers across the community health division who are strategically placed throughout our traditional community benefit programming. But more recently, we have created a community health worker hub, which acts essentially as a form of air traffic control, but also a safety net to ensure that every single patient who walks through our hospital doors is screened for at least one non-medical driver of health. Something, or I'd say a misconception for some people when it comes to non-medical drivers or social drivers for everybody else, they associate them more with the underserved, the uninsured, but all of us, regardless of your race, your ethnicity, your gender, your sexual orientation, we all have them. It's just a matter of how are they showing up in our lives. So we have a community health worker hub that we started just at the end of last year, at the end of 2025. And they serve two purposes. One, as I said, every patient who enters our hospital, we want to make sure is screened for at least one non-medical driver. If they are discharged from our hospital before our community health workers can get to them to do that screening, because they're the ones who do it in the ER setting and inpatient, that patient receives a follow-up call from our community health workers that are positioned in this hub that, one, hope your stay was good, which I know is weird for a hospital, but also we're doing it so we can capture those non-medical drivers. Specifically, we lean into asking questions about food, housing, utility assistance, transportation. And then after those four, it just really depends on the direction the conversation goes. So that won't be new for anybody in this space. So we capture the non-medical drivers on that side. And then of course we're doing it, directly when in front of the patient. So first, once we understand what is negatively impacting our patients from that regard, we then are able to make the appropriate referrals. Sometimes those referrals go out to external nonprofit organizations who are best equipped to address things like food insecurity or housing based on where the patient lives. But where I think Memorial Hermann gets unique is we have a lot of our own in-house programming that we're able to refer these patients to. You will probably hear often with different healthcare systems, they're screening and then they're referring them out to nonprofits, and we want to reduce readmission. So you got to get them out your hospital and get them locked in somewhere else. That is not our approach. We genuinely, authentically are trying to help get them established in the best place possible. So we will refer them out to other organizations who have the ability to serve them in their community. But what I like about our system is that we have charity clinics that we operate. So sometimes those referrals, especially if it's an uninsured or Medicaid patient, that referral will go right there to our neighborhood health centers, which are charitable clinics that cater to that population, where we can provide not only primary care, but have started to expand to provide more specialty care. Very recently, we just hired our very first endocrinologist, speaking about diabetes, who's dedicated to our neighborhood health centers. And so that is our approach to making sure that we can truly provide that diabetic care in-house for these patients. And then layering on the non-medical driver piece, if we also have already come to understand that they are food insecure, we also operate in-house food pantries. We have what we call community resource centers. Their whole focus is addressing those non-medical drivers that we uncover in our populations. They can do anything from helping people sign up for SNAP, which our CHWs will sit there with them in person or telephonically and help them fill out that application and get it submitted, because it can be a complicated process. Language barriers can sometimes be an issue, so our CHWs come into play there, all the things. We help them sign up for Medicaid if we determine that they're eligible for Medicaid and they just haven't taken the steps to sign up or didn't know they were eligible. Utility assistance, but then also within our community resource centers, in addition to those eligibility applications, we have food pantries. So when our patients are screened as food insecure and need emergency food, we have the ability to right there in our pantry address that need. If they're housing unstable, we have the ability to get them, do a warm connection to the organizations in our community who can help address those things. Beyond the community resource centers, which are our main mecca, of addressing non-medical drivers, and our CHW hub that's uncovering them. As I said, we've had our neighborhood health centers that creates that clinical care piece. And then I want to take it back to our other priority area I mentioned. So diabetes is one, and then our NHCs address hypertension and the others.
Yeah, you have so much incredible work going on that is so mindful about making those connections and making care available where people are so they can get the services they need to be healthy. I know this is complex and long-term work, and it's not going to solve all of the issues today or tomorrow, but as you're looking towards the future, where do you see this going? And what would Houston look like in 5 years if this work was having the impact you wanted it to?
It's hard to predict where we're going. I can tell you where I'd love for us to be. And it's, from a healthcare system perspective, all these things that I've talked about is truly a ecosystem where somebody comes in our hospital, we understand their non-medical driver needs, and then we're plugging them into their medical home at our neighborhood health center. And then we learn that they're food insecure. So we get them locked into our food support programming. And then we figure out that they are unemployed. So then we link them into our workforce development efforts, which are also part of our investment, like somebody who we can fully wrap around with the approach that we're taking from an economic side all the way to the direct care side. And then seeing that patient or person ultimately thrive. And then hospital language, you see them then, hey, and they didn't readmit. You always take it back to that. The other part of me, though, where I would like to see things go, at least in this community, and I don't know fully what it's like in other communities, is I would like to see these large employers here in Houston, not just healthcare systems, but energy companies, higher education, colleges, universities, oil and gas, which is very big here in Houston, hospitality, all these major employers in Houston. We are a major hub for business. All of us coming together and recognizing that we all have a piece or a role to play in this. There are people who are utility, or electricity insecure. They can't afford their electric bill, and that has health implications. So you have those major utility and energy companies saying, okay, well, we're going to own this piece in collaboration with you so that we're not operating in a silo, but we're linking everything back to what the healthcare system is doing. And then the universities are saying, we're going to own this education piece, and we're all working truly as a network. And I know that sounds very idealistic. It can be done. It's a collective, social, corporate agreement that everybody has to come to, and everyone's going to own a piece of it, rather than what I think we are starting to see, which can work too. But we're starting to see, different bodies try to take on all aspects. Like everything I described here in healthcare, it is our responsibility because we care about the health. Like we are a healthcare system. We need people to be healthy. And if that means we have to help people with transportation, we're going to help them with transportation. If it means we're going to have to invest in affordable housing, we're going to do that. But if you step back, I believe this is our responsibility. But how much more effective could this work be if HUD said we have an agreement with the TMC, Texas Medical Center facilities? And so healthcare systems, when you uncover somebody's housing insecure, we have a fast pass process to get that patient or that person, what they need. I'm still working it out in a more succinct way to say it, but I would just say just this corporate convening where we all own our piece while working under the same objective and outcomes reporting to actually transform. We all have enough funding, on some level to do something amazing. So that's my idealism on full display.
I think the thread from all of these answers that it's all about the ecosystem. It's not just one program. Within the world of things that contribute to health, there are healthcare systems, there are social service agencies, there are community-based organizations, there are other companies. Everyone has a part to play in creating healthier communities. So we're going to check back with you in 5 years and see how things are going.
Yeah, ask me in 5 years.
Perfect. Well, thank you so much, Ryane. This has been fantastic, and we look forward to hearing how this work continues to evolve and grow to serve the communities in Houston.
Awesome. Thank you so much for having me. I always like talking about all the work we're doing in our healthcare system, my passion, for helping. And I will continue to push my ideal vision of this massive convening where we don't just talk about it, because that's very common in our space, but we're actually acting on it. So
love it. Thanks so much.
Thank you.
Thanks for listening to Advancing Health. Please subscribe and rate us 5 stars on Apple Podcasts, Spotify, or wherever you get your podcasts.